लेके चले हैं, that was a wonderful thing. Most of the time you were on the track, but कहीं कहीं आप out of track हो रहे थे. आपके एक जो केस तो प्रेजेंट किए हैं ना आपने, जो पहला वाला केस था आपका 40 years फीमेल, मेनोपॉजल औरत है, हाइपरटेंसिव है और उसको एटिपिकल सा प्रेजेंटेशन है. Why do you think this patient will fall into low to moderate risk, जिसका आप सीटी करा रहे थे? एक ये जवाब दे दीजिए, ठीक है. दूसरा जवाब, आपका दूसरा वाला जो पेशेंट था 65 years वाला, who was with typical chest में, and this is the first time he had come. He was not a diagnosed case of chronic coronary syndrome. Chronic coronary syndrome can have acute episode of acute coronary syndrome. तो आपका ये जो था ये chronic वाला नहीं था, तो इस केस को इसको chronic में नहीं. This is how I think it. ये इसको first episode हुआ था with so much comorbid, so he should have been taken as acute coronary syndrome rather than chronic coronary syndrome super added as acute coronary syndrome. इस तरीके से आप present करते हैं. Rest you can tell me.
Thank you, madam. Thank you for your comments. First lady was 40 years. She was hypertensive. She have a control symptom. I have just short this his history because of multiple of slides. She has a good function class, and she just came to us with his for a screening test or for any future to prevent to be healthy and to prevent in future events. That's why we have advised her a CCTA. Second patient of, if I think you have seen the slides. Second patient who was 65 male, he have a symptoms of chronic syndrome since 6 months. Just he came to us with a further evaluation, and that's why we have advised him as any functional test.
तो फर्स्ट एपिसोड था ये, क्रॉनिक नहीं था. क्रॉनिक ऑन
madam, he was
yes,
he has 6 month history. He has 6 month prolonged history of angina, and he have now he came to us with a further evaluation, but his symptoms were stable. His frequency of pain, his severity of pain were not increased. He just came to us with his further advice.
Okay.
Yeah, I think it was a comprehensive talk. There is no doubt about it.
Thank you, sir.
I just have to emphasize on a couple of points. One is CTA, that is CT angiogram. I would use CT angiogram in young patients. In people over 60 or so, I think in view of renal functions, which may be compromised, and when we give contrast, even in normal kidneys are affected. So in older patients, particularly diabetics, their renal functions may not be 100%. Even if creatinine is normal, but remember, creatinine level times age will tell you exact eGFR. So giving contrast, which is 75 mils, whereas an invasive coronary may take 20 mils only. So I think we need to consider this fact in patients who are 60 plus. In younger patients, yes, it's an excellent test. Second thing about calcium score fallacy, its sensitivity is 97%, which is very good. That does not mean 100%. I think about 6 months or 8 months ago, I had 2 patients whose calcium score was 0, but I had to put 3 stents in one and 4 in another. So we should go by clinical history also. If the patient has symptoms, so our clinical judgment is very, very important.
Yes, sir. Of course.
Another thing is about statin dose. We have thinking that statins are a bad drug. I have used full doses, 80 milligram of atorva and 40 of razua routinely. The fallacy really is once they achieve a target of around 50, people tend to cut down the dose, which is totally wrong, because the day you do not give the statin, the LDL factory will work. So that is another important point related to chronic coronary syndrome in particular, because patients are stable. I don't see them in 3 months or 6 months or even a year. So we should be very clear that they should continue the dose. And finally, dual antiplatelet. I've seen very commonly that patients who are stable, who are on aspirin or clopidogrel, routinely, whoever sees the patient, they add they put them on dual antiplatelet. So I think we should not forget that the benefit is almost negligible, but bleeding risk is there. So we need to explain this to our colleagues also, particularly non-cardiologists who do that. And finally, in this age of media, the WhatsApp stories, I call them WhatsApp gurus. He tried to convince people that cholesterol nahi hai, and this is all blah, blah, blah. I think we should explain to our patient that please ignore all those messages. So much so that I've noticed many of our colleagues are actually impressed by them. And remember, if somebody is a good speaker, is a good debater, let me tell you an example. We have known great debaters. If you ask them to speak for, they will do a great talk on for. If you ask them to speak against, they will give a great talk on against also. And they're very convincing both ways. So we must watch out for those things. And I think with that points, I've really enjoyed listening to, although I was busy with the clinic also, but I was listening to you. You have presented it very well.
Thank you, sir.
Mashallah,
Thank you.
it was
Just
interesting. I've learned a
word
lot.
of comments. I am grateful to Mehfooz Shah and the seniors,
Thank you, sir.
especially Professor Mansoor Saab and Dr. Abiba. They have contributed a lot and detailed the points which were kept short, which are not included in this. And she and Mansoor Saab very nicely said. I am glad that Sukkur chapter is also active under the leadership of Tahir Sumro, is newly selected. But,
So next time कब बुला रहे हो सक्कर?
hello. So thank you all for joining, and special thanks to Sayyid Tahir Shah. Thank you all.
Wonderful.